Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Saya ucapkan kepada semua hadirin yang dapat bersama-sama kita dalam sesi webinar CME pada hari ini. Untuk pengetahuan semua, sesi webinar CME ini adalah kerjasama daripada pihak Kerajaan Negeri Selangor melalui program SEHAT iaitu Selangor Mental Health dengan kerjasama daripada International Islamic University Malaysia IIUM dan juga Malaysian Psychiatric Association MPA. Untuk sesi pada hari ini, tajuk kita ialah We Love You Child, iaitu memberi fokus kepada masalah kesihatan mental yang berlaku di kalangan kanak-kanak dan juga remaja. Bagi golongan ini, masalah kesihatan mental akan diterjemahkan di dalam aspek kehidupan harian mereka, terutamanya daripada segi behavior, dari segi kelakuan mereka, ya. Dan kita juga pernah mendengar tentang gejala-gejala kemurungan, anxiety dan juga psikosis yang berlaku di kalangan kanak-kanak dan juga golongan remaja. Tetapi bagaimana untuk menangani masalah ini ataupun untuk menghadapi masalah ini, untuk manage masalah ini di peringkat primary care. Untuk itu bersama-sama kita ialah seorang pakar psikiatri yang memang sangat specialized, yang sangat arif dalam bidang child psychiatry and adolescence, iaitu Dr. Aili Dr. Aili Hanim binti Hashim, iaitu seorang pakar konsultan adult child and adolescent psychiatrist daripada Universiti Malaya. Kami sangat berbesar hati dan sangat berbangga mendapat kerjasama dan juga mendapat tunjuk ajar daripada Dr. Aili pada hari ini. Tanpa melengahkan masa, saya menyerahkan sesi ini kepada Dr. Aili. Silakan.
Thank you, Dr. Faizal. Minta maaf ya, saya sebenarnya I'm going to try and speak in two languages.
Yes, okay, Doctor. Can mix English and Malay.
All right, thank you. I wanted to say is actually I've retired from PPUM since April.
Okay.
So I'm enjoying my retirement life. Okay. Can I share the screen?
Yes, please.
Thank you.
And to all participants, feel free to type your questions in the chat pane, yeah? And we will address all the questions at the end of the session.
All right, let's see. Okay. I've asked the organizers to change the content, mainly because having dealt with this issue of child and adolescent. Actually, child and adolescent for me is a very interesting topic, and that's why I ventured into this field. Interesting, but it's as well as challenging. Okay, the topic too, as what I said, I tweaked it a little bit. And one of the things the reason why I tweaked it is because of the experience that I've had, mainly because when we say we love our children, do they actually feel love? That's the thing that I think we have to do or to think about as adults. And for this presentation, I will mainly talk about mental health difficulties in children first. Sebab I think this is something which is it is very complex in that sense, very abstract, and people say that they know, but in actual fact, from my experience dealing with mental health, I think people misunderstand, and I think primary care is a very good level of entry, and I always feel that primary care physicians are my agents of change, because this is where we can pick up many of these mental health difficulties very early. Okay. And I will cover, because I've got I have two sessions this week and next week. I would like to as well cover what are the factors affecting child development, not just the disorder, but factors affecting child development, including the parent-child relationship. Okay, why I wanted to talk about this is what I said. Mental health physicians, primary care physicians are my best colleague ever, because they can pick up things easily and they can do the referral as soon as they feel comfortable. Children and mental health is very concerning, sebab the reason is, despite effective treatment, there's a long delay between when the individuals are first experience clinical symptoms and when they are eventually seen in the mental health service. And part of this long delay is because of this level of understanding and acceptance. And of course, all of you will understand the stigma and fear associated with just the term mental health difficulties. So what we do know, and this is especially not just in developing, but as well as in developed countries, that if you fail to invest the time and resources of the knowledge, the cost to the society is actually far-reaching and very concerning. So let me talk about first what is mental health in children and what is mental health disorder. Sebab of the misunderstanding. So mental health is the way that we think, we feel, we act, we behave in order to face our life situation, right? Basically how we handle our challenges, including how we relate to other people, how we think about our options and how we make choices, right? So that you can see this definition, it involves the individual's cognitive, emotion, as well as rational thinking. So if you look at this, we begin to ask ourselves, where do children learn these skills? Where do they learn? When do they learn? Right? And what if they don't learn these skills? What happens to them then? All right? Okay, these are things which are, again, very important. So this is the relevance of why kids are what they are, who they are. And the theory is that, it is based on their interpersonal factors, right? They are born with certain characteristics, which would then interact with the environment. It includes their families, their siblings, the extended families. Then after the next 6 years of life, the first 6 years of life is of course the parents, the siblings, and maybe the extended family. And then in the next 6 years of life, from school going age onward, it is their peers and other adults in the environment, which includes the teachers and so on and so forth. And what goes on in the environment, right? And what is affecting their parents as well as affecting their siblings or the extended family. So these are rational process, and you all can understand that these are processes which goes on invisibly or unconsciously, right? But it is still affecting the children. So kalau kita talk about mental health problems pula, mental health problems are situations whereby it involves behavior, emotional, performance, academic. Okay, the reason why I put here academic is because it's so Asian, right? Our country, especially in the Asian countries, whereby academic performance is so important, and including interactions with others, which is a concern. It causes distress. So it becomes a disorder when the situation is severe. Okay, so the definition here again is any abnormality of emotions, behavior, performance, academics, interaction with others, which is severe and impacts the child's development, functioning, relationship to others. So again, it's a very broad spectrum, but it covers all the relevant information regarding the child's development. Okay. So, and what we see even in our country is that the increasing number of children with mental health difficulties and is persistent and severe. And if we don't do anything maksudnya, we don't detect, we don't intervene, these, by the time they reach mid-adolescent, things like learning difficulties, behavior, the emotional, it gets worse, which is understandable. Now, I'm not going to go into the common childhood disorders, but I would just mention it. Things like the various groups or characteristics of this will be the neurodevelopmental disorder, the psychotic disorder, the mood and anxiety disorder, the externalizing of behavioral difficulties, the substance and other things like eating disorder, gender, so on and so forth. Okay, so again, these are some examples. The neurodevelopmental disorder, macam intellectual disability, learning disability. These are two different situations here, intellectual disability and learning disability, the ADHD, the autism or Asperger's, which was formerly, this is what DSM has now included in the autism spectrum disorder, the impairment of speech, motor, tics, and so on and so forth. Okay, the neurodevelopmental disorder, this is one is the most common things, again, which is commonly missed. As the name suggests, it is primarily the functioning of the neurological system and that of the brain, whereby they can have a mixture of, for example, language, speech, motor, behavior, learning, focusing, and other neurological conditions, which invariably it is more than one symptom. You can see it in the children, and the symptoms change or evolves as the child grows older. And I'll show you what I mean by this shortly. And therefore, the diagnosis or treatment of this disorder can be difficult because it's not easily or not early picked up. Okay, so what do I mean by this? Now, I thought of explaining this a little more partly because this is what I see in my experience here, whereby the child may appear to be normal, or the child's difficulties are manageable or tolerable at birth. Okay, but as soon as a child enters early childhood, i.e., for example, when they go to preschool, for example, right, some of the difficulties can already be picked up. For example, the behavior, the interaction, the focusing, yeah, and it's not too bad in that case, or it is sometimes quite severe. But then if you don't do anything about it, yeah, as you go into middle childhood or in adolescence, you will see more of these difficulties, right? So it becomes more obvious as the child grows. Okay. Now, an example would be the learning. Learning maksudnya the reading, the writing, speech, the inattentiveness or the fidgety, restless behavior. Yeah, it can be seen during the preschool age. And then more difficulties definitely and invariably, and it makes sense as the child goes into the primary school stage, whereby by then they are expected to be in class, they're expected to pick up learning, they're expected to perform. So you can see these difficulties such as learning, the speech, inattentiveness, yeah, you can see it more relevant, more significantly in the primary school age. And as you go into standard 6 or standard 5, for example, it becomes more concerning, but invariably it's not necessarily recognized. And it's not necessarily recognized partly because people sort of downplay it or normalizes it. Yeah. So again, it's not being picked up. Okay. So what happens here, and the reality, this is what happens, it is happening in the society, whereby minor delay or some or no developmental delay, the difficulties increases, becomes noticeable, but it is not necessarily picked up. Okay? So what happens here is that they do not get help, while some do get help in their later stage, but many of them do not get help. Now, what I mean by this, again, this is something which is so common. I can tell you in every school there is a similar scenario whereby children are struggling with learning and with learning, behavior or emotions. Yeah, they're struggling to cope. And what happens, because as they grow older, for example, even by standard 3, 4, and then 5 and 6, it worsens. Yeah, they are this batch of kids whereby they are in the last class, they are struggling with the academic or behavioral problem, or they are inconsistent with their school performance. Yeah, and again, it's not identified the mental health problems. Why? Because people think this is more behavior, right? They do not see it as a mental health difficulty. As what, if you go back to my earlier slide, in my earlier slides, says it, mental health difficulties is a combination of, which includes behavior, right? Academic interaction with others. But here, because they do not seem to perform, right? What happens normally in these kids, what happens in these kids, they are labeled, right? Or they're dismissed, but there's no intervention. Okay. Now, what are these childhood disorders, common childhood disorders or mental health disorders? Yeah, these are the highly prevalent, low severities, things like ADHD, specific learning disability, which again are more likely to be dismissed compared to disorders such as mental handicap, cerebral palsy, for example, whereby it's low prevalence but very severe, whereby you can easily picked up. Okay, so you can see the two scenarios. Now, the presentation of the children usually that gives you a clue or makes you think about maybe this is mental health difficulties are children with learning and developmental delay, children with speech and communication with others, children with behavioral difficulties interacting with others, children with difficulties following, remembering instructions, children with difficulties staying on task. And then in later years, if these are not picked up, later years, then you'll see the mood, the negative thinking, the anger, aggression, and another difficulty that affects a child's mental health and could give rise to mental health difficulties are parents and parenting. And often you can see a combination of symptoms that suggest that this is mental health disorders. Okay, so this is what I'm saying here. If you see your patients with a combination, 1, 2, you see your patients that you've seen earlier and still having difficulties, and the difficulties are progressing, it's not decreasing, please consider, is this a mental health disorder? Okay, because to this day, it is still dismissed, it is still normalized. Okay, so what happens here? Why am I paying much attention to this issue is because if things are not picked up and not picked up early enough, right, it increases in difficulties, right? For example, a child who has difficulties paying attention, right, eventually, and you can see as the child grows older and you standard 3, standard 4, standard 5, standard 6, as the lessons get even, the lessons get harder, the child is falling behind, right? Or you can see the child performing erratically, or the child putting in a lot of effort. And what happens to the child is that they develop low self-esteem with no validation, but increasing expectation. And then the severity of the disorder increases. That's why you see kids with self-harm, depression, substance use, including internet addiction. Okay? Now, this is an example of an email, this one. So remember I showed you this earlier? Last in class, struggling. Some would have discipline problems or no discipline problems. And this is a common scenario. Kids who have inconsistent performance, they have to put a lot of effort to meet their expectation of the adults. So this is one I just received this email two days ago. One of my patients who's she's 17 years old, all right, and she wrote this to me. My parents, she's still in therapy, but I think she might have dropped out. My parents make me hate myself, right? My parents make me want to kill myself. My dad makes me want to overdose my medication. My mom makes me hate my body. I want to hurt myself so much, and I hate this body. I hate myself, and life was so much better as if I was never born. And this is an example of a child who was struggling with attention, performance, and to be able to perform similar to a brother who was a straight A student. And because she couldn't perform, right, they pushed her to attend tuition. They pushed her eventually to go on to boarding school. She couldn't fit into boarding school because she was just practically putting in a lot of effort to try and be consistent in her performance. And a year ago, 2 years ago, she told her parents, I want to leave the school. Parents persisted. And now she's depressed. Not only is she depressed, you can see it here. She's suicidal. You can see it here. That she also has low self-esteem. And from a person who had difficulties with academics, and now you have a bundle of difficulties, and you can see in this situation it's really, really challenging in terms of treating this individual. Okay, so here we go. So what happens here in the earlier slides, what I left out, but is a significant problem which we have to take into consideration is how family difficulties affects the presentation, affects the cause, affects the prognosis of a child with mental health difficulties. You see, what happens usually is the child comes to the mental health service with self-harm and depression, right? We treat, i.e. with, for example, antidepressants, but we often leave this out, the family difficulties and the child with low self-esteem. Hopefully, I will try and cover how you guys can form some form of intervention at the primary care level. Okay, so what are the family difficulties that I'm talking about? The family difficulties that I'm talking about is disruption of family by separation or divorce, marital conflict. Okay, not all families are the patients that I see, not all families come from parents who have separated or divorced. I see a lot more cases whereby the parents are still married, but there are usually presence of marital conflict. The presence of high expressed emotion. Oh my goodness me, this is my number one problem with parents. Sorry. High expressed emotions means they're so negative. Yeah, and in cases, there are also cases of abuse and neglect, which also parent-child relationship difficulties. Yeah, and other things which are most likely to be missed in terms of when we're seeing the cases. Okay, so what I'm trying to say, okay, the other thing which I found really interesting is childhood trauma. I used not to see individual childhood trauma not so often, but in the later years, particularly during the COVID, that was something which I thought was really interesting. I began to see a lot more individuals, i.e. adolescents, with childhood trauma. So childhood trauma in our patients is common. Right? When I talk about trauma, it is usually has happened because of someone in the family has done something to the child. And usually this experience have been in the early childhood, maybe when the child was 6-7 years old. Yeah. And it has been going on for some time. In some situations, the parents do know. In some situations, parents do not know. Right? They do know, but they have, again, minimized the situation, thinking that the child will not be so affected. Right? The situation, because the trauma has happened in the early primary school years, for example, we think that the child will not be so affected. But by the time they reach adolescent and then they realize what has happened to them, then they also realize in terms of support, whether they have or do not get the support, that's where, boom, the depression and the self-harm occurs or aggravates. So and in this situation, particularly if the trauma is not being disclosed or the trauma has been minimized, right? The child feels bitter, distrust, unloved, and unsupported, and it affects the parent-child relationship. Okay, so I would always put red flag in terms of if there is presence of marital disharmony, if there use of threat and intimidation and aggression. You can read this. The reason why it's a red flag, right? It is not just to treat the child, but to treat the situation of the parents. And it's the red flag because not all parents are open to the idea of receiving help for whatever it is that's happening in their marriage or relationship. Okay, so, but having said that, this is an area of intervention, much needed intervention, because to me, if the captain of the ship is not stabilized or not stable enough, then of course, right, if the nahota kapal is not stabilized, then of course, the anak-anak kapal would not be able to stabilize, or it's difficult to stabilize the anak-anak kapal. Okay, right, short pause. You want to throw me a question for now? No?
At the moment, no question from the chat.
Okay.
Any last question?
Wait, hang on. Well, I just hope people can follow what I'm trying to talk about, because I remember that we had to try and not use up the whole hour. All right. Okay, let me see. So, okay. just let me summarize what I've just said is that, yes, there are medical conditions which give rise to mental health difficulties in children, and the presence of difficulties in the primary support group or difficulties in the family will contribute to the child's mental health difficulties. Okay. Now, because of the difficulties, these medical mental health disorders, it can actually be easily identified. Sorry, I use the word easily, is because once you are aware of it, as what I said earlier, for example, that you're seeing the child and you've been seeing the child for many years, you can see if things have not gotten well. Okay. And also, which I will talk about in my next lecture, is to do this mental state examination. And in the mental state examination, what I usually do is I look at the bigger picture, right? The bigger picture, not only just as a child, I look at the interaction between the parents. Yeah. So that gives me a clue of things that might also be happening in the child's life. Okay. So when we talk about child and mental health, as you all can see, that's what I said in my first slide here, right? Childhood and adolescence are critical period for anybody's mental health. Okay. When I talk about children, I mean anyone below 18. Okay. Now, and you can understand that in the early childhood years, that it is a time for rapid growth and development. Right? It is the time that we pick up skills, for example, especially skills about anger control, skills about control stress. And these skills are important because this will shape the mental health of the child. Okay, what do I mean by this? Now, the attachment theory talks about, and again, I will talk about it in my next lecture. The attachment theory talks about, it's literally like when we build a house, right? And what does it mean? The foundation of the house has got to be strong. And the foundation of children is the family. So if the foundation of the child is not strong enough, definitely, and this is what theories have shown, research has shown, if the foundation of the child is not enough, and the child has got mental health, neurodevelopmental disorder, for example, ADHD, and the foundation is not strong enough. So a child with ADHD and with not a strong enough foundation will have more difficulties than a child that comes from a stable enough environment. Okay. So why do I say this? Because in the early years, what is it that the child learns from the environment? In the early years, the child learns about who they are as an individual, right? Whether I'm worthy enough, whether I'm loved enough. Okay, right? So they learn about who they are, right? How they relate to others or to themselves, whether their relationship with whoever is in the environment is trustworthy enough or otherwise. They also pick up thoughts and ideas. They also pick up thoughts and ideas about how to think about other people, how to communicate with other people, how to react and behave, particularly when they are faced with stresses. Okay, so, and what is really important here is from here, they will get to know whether they can be independent enough. They will also get to know what is it like to have a support system or not support system. So it is very important, as what I said, adults need to stabilize, because if adults don't stabilize, all these things will be missing or will be abnormal in terms of how the child perceives themselves and people around them. Okay, so this is what I talk about. This is what attachment theory talks about, how childhood interactions and experiences with their early childhood interaction and experiences with caregivers shapes the child, right? And whatever it is that they perceive or they experience are often internalized by the child and continues to shape the child as the child grows, and his responses to the external events as the child becomes an adult. Okay, so because of this, if we do not take up or do the necessary things, what happens here is that countless kids, and this is happening in our society, right? And mindful is what I said, it's not that the parents are divorced or separated, the parents are still together, but the environment that they provide for the child is less than ideal. And what I've seen in the last few years of my working life is that countless kids, and it is really scary, countless children grows up in an environment where the developmental needs are not met. Okay, so what happens here is you can see the rise in children presenting with depression, and parents are always, or adults will always ask me and say to me, why would kids be depressed? Because they don't have the insight, right? To them is that I have provided my child with good education, a good home, but they forget whatever is happening to the home is also affecting the child. Okay, so that's why you can see, and that's why I need your help to pick many of these children up at early enough, because we see a lot of children presenting behavioral difficulties and depressive symptoms, and when that something is not right, that's why they gravitate to drugs and alcohol and sexualized behavior. Okay, right. Anyone wants to ask any questions for now? Because I think I'm going to finish very soon.
Yeah, there are three questions here. The first one from Dr. Rashid Ali. How can we bring the child out of a trauma when they struggle to come out of that zone?
How do we bring them up? Oh, that's why they need help. They need therapy.
Okay.
Yes.
And the therapy, meaning to say we refer them to the child psychiatrist rather than to manage them at the primary care.
Unless you all can do it.
Okay.
If I tell you next week, it sounds simple actually. It does sound simple. Maybe most of you can do it actually.
Okay, basically, from your presentation, you also outline the underlying problems that the child might be having when he or she presents with the anxiety, depression. The underlying problem might be from the marital status of the parents, right? And any other thing that's happening at home. So how do you cater the parents? Because we don't want them to be in denial, or we don't want to make them sound defensive or anything that relates to the parents rather than the children.
Okay. Now you're forcing me to do what I'm supposed to do only next week.
Oh, is it? Or do you want to
No, it's okay, it's okay. No, it's okay. Okay. The answer to your question is, one is we have to be mindful about what's going on. Okay. So once you're mindful about what's going on is, how do we offer help to them? Okay. And you're right. They might get defensive. So I even though I'm a child psychiatrist, but I'm trained as well in the psychodynamic manner to use psychodynamic, and I use all psychodynamic understanding theories and principles in my line of work, right? And psychodynamic understanding and principles, it means that I have to find ways of getting the parents to speak about the problem. So what do I do? Okay, I need an example. Okay, let me give you an example of this couple who brought their 13-year-old son, who has over the past 1 year has progressively isolated himself in the room, right? And if he does have any interaction with the parents, his interaction with the parents is always about he's always snapping. Yeah, he's always snapping at them. He refused to come and have meals with them, and he has his meals in his room. He feels unhappy even going to school. So when they come for the child. Okay, but you can see it. The husband and wife sit so far away. Their interaction is very stiff. Husband snaps at the wife. The wife snaps at the wife snaps at the husband. right? So I'm trying to get the history about the child here. And then I say, hey, what's going on with both of you? So they keep quiet. They behave for 2 minutes maybe. Right? Then they start again. All right. And then I will say, and then I said things like, is there something that I'm missing here that you're both snapping at each other? Then they say, hey, we're here for the child. Okay, fine. Right. So this goes on again. And then I said, look, I think there's something not right here. Okay. I'm pretty sure that this kind of interaction, right, is not only happening in the room, but it also happens at home. Quiet. And then I describe that you both seem very upset and impatient with each other. And then out they come. So what do you think the technique that I used just now? Anybody wants to give a clue? You cannot react yet.
Psychodynamic?
Yeah, but what part of psychodynamic?
Oh, what part? I don't know.
Sorry?
Oh, you're not sure which part. But
Somebody is saying something just now. They cannot speak up ke?
Can. You can speak.
Can, Anybody? Okay. Don't worry, guys. I'm not your teacher. Okay. What I just did just now was that I just describe it. What I see. 1, 2. How do I describe it? That's also important. Okay. So I don't use words like, kenapa gaduh-gaduh ni? I don't use that. So if you see, I'm looking at left, right. I mean, I'm trying to imagine it so I can come up with the words, because if I don't see it, then it's difficult for me to word what I see. So I try and visualize it, and then I will say it. But I have to say it in a calm manner so that they do not feel exposed or don't feel so shameful or so exposed, right? And I don't know whether you get it, because I also try and sound that I'm concerned, which is true. I am concerned. Right? No doubt the child has got difficulties, but this fight and this fighting in the room is also a concerning matter for me. Yeah, so that's how I try and get them on board. But of course, sometimes, as what I said, I don't have social media because I think my number one enemies are parents. They will not accept what I have to say. Okay, but through these years, as what I said, I've retired. Through these years, I play the waiting game. What does it mean? It's okay. They want to leave. They don't want to come back. But eventually, some of them do come back, right? Or they go somewhere else. But at least they go somewhere else and they get the help. So the first instinct is, that's what I said earlier, and that's why I made this presentation like this, is that recognition. People will always say, tak adalah doktor, kat rumah kami tak macam ni. Nah, that's not what the theory says. The theory says, if you behave like this in my room, that's exactly how you behave at home. Right? And this is what I said in the presentation. Where do kids learn about who they are? Where do kids learn about communication? Where do the kids learn in terms of behavior? From home. And the theory says it, but the parents will say they learn it from school. So you know that's resistance. So in your head, you need to figure out how to bring down resistance. Okay?
Yeah. Right. Another question, Doctor.
Yes.
To whom should we refer in case we have identified a child or teenager with autism or any other mental health issues at the primary care? Are there any organizations or NGOs we can seek support as parents with children suffering from autism?
Okay. Organization ni I'm not up to date in terms of organization. But I think in terms of primary care, okay, kalau let's say kids yang in primary, very young children, 4, 5, 3 years old kan, if they have difficulties, I think you need to refer to the developmental pediatricians. The reason being is I also make use of developmental pediatricians. It's not pediatricians, yeah. is developmental pediatricians. There are very few of them. They are in the general hospital, ada in private private services pun ada. The reason being is children with difficulties in a very young stage. I always would like the developmental pediatricians to investigate in case I miss out other neurological disorder, right? And dulu when I was working, yes, there are child services or child unit in most major hospitals actually. It's just that the waiting list has increased because of the number of cases that we have. There are also some private child and adolescent psychiatrists. Okay.
All right. Any other question? Live questions? Okay, there is none. Maybe Dr. Aili can proceed with your presentation.
Yes, kejap ya. Just give me a little bit more. Okay. What I wanted to tackle here is the things that I have been seeing and handling now. Pause, okay? Now, I used to see, I think maybe 4 or 5 years before my retirement, I began to see a lot of children with children and adolescents. Children means anyone below 18 with depression. And the situation has increased during the pandemic. It is really scary because the level of the severity of the depression is severe, and they come with thoughts of self-harm. Okay, so what I would like to say is adolescent depression is actually real. Most disorders in children, in fact, the mood disorder is the most common child and adolescent psychiatric disorder. And even in my pre-retirement years, I still see children or adolescents with depression. In fact, this is my main interest, is adolescents with depression, adolescents, young adult with depression, and ADHD. This is my main interest. Okay, and if we don't do something, yes, there are serious consequences. Even for me, even as a psychiatrist with many years of experience, when a child is suicidal, I'm very much heightened. I'm afraid, yeah, because they can do anything, and it is very, very, very difficult to reach them in the state when they are suicidal. So, and why do they become depressed? Yeah, because of various reasons, and you can see, right, the depression impairs their functioning in terms of social and academic. Right? It is not that they are lazy, right? They can't, because when you're depressed, is that your brain sort of slows down. Your negativity becomes more negative. So it's difficult for them to get out of bed. It's difficult for them to even eat or even go to school, for example. Okay. Now, the depression in adolescence may not necessarily be low mood. It is usually a mix of low mood as well as irritability. And that's what adults see and feel, that they are being rude. In actual fact, they're not rude, right? They are depressed. Okay. Now, and because of that, it is frequently ignored and misunderstood. I just had a father who's actually playing games with me. The daughter is like playing games because the daughter wants to come for treatment, but he's been missing the appointments. He says he forgets her appointment. And the main reason he feels the daughter is depressed is because hari dunia nak kiamat. So that's why he's not bringing her for follow-up. Now, in relation to this, adolescents, 5% of adolescents with pre-pubertal 1 to 2% can be depressed, right? We see more girls, though the boys who are depressed, they are more aggressive, but they are still depressed. You can see more irritability in them. The lifetime rate is 15 to 20% of the population, which is again comparable to the adult population. And studies suggest, and this is true because I have a huge pool of young adults in therapy with me, many of them start to have their depression during adolescence. And this is very true. And 5%, 50% of depressed adults have the episode before the age of 20. Okay, it is recurring, it can be spontaneously remitting, right? It can last for about 7 to 9 months, but it can last even longer. And in 60%, it can go right up into adulthood. Okay. The predictors of recurrences are the poor responses, the severity, the chronicity, and if there are several previous episodes, presence of comorbid like attention deficit disorder, family problems, yeah, and presence of hopelessness and negative cognitive style. Okay, so these are some of the risk factors. So you can see invariably, yeah, as what our chairlady did ask, yes, invariably I end up offering help for the family as well, for the parents as well. Okay, so these are common comorbidity, anxiety disorder, post-traumatic disorder, behavioral. Now, attention deficit disorder is again a common disorder which is commonly misunderstood and missed, right? And the reason being is that for me, again, I have a huge pool of ADHD adolescents and now adults, because you see, ADHD, they have very different picture. And a child with ADHD is no longer a child that is constantly running around. A child with ADHD is a child who is not a child who cannot study. They can study. In fact, my ADHD adults or adolescents are brilliant, right? They have very high IQ. They don't study, but ADHD has a very high risk of family difficulties as well as high risk of depression, anxiety, and substance use. Okay, so that is why I said you have to pick it up early, because the sooner that we pick it up and give an intervention, the better the prognosis. Okay, so and depression in children and adolescents is very complex, and invariably I use a biopsychosocial approach, i.e. I mix it with medication as well as individual work. Okay, now the other understanding is that people think that you use depression maybe for about 6 to 8 weeks. Not true. Many of the individuals will probably end up in the teaching of the American Child and Adolescent Psychiatry is that you continue for at least 12 months. And if you do want to take it off, you have to make sure that the child is not facing or can be handling his or own stress appropriately. Then only you can consider. But in situations of ADHD, usually for me, I always advocate that as long as the child needs it, and the child needs it usually by the time, because after they finish high school, they have to go to university. Invariably, some adult ADHD don't need it, or they need it periodically. So these are things that we have to take into consideration, because no one plan will fit everybody. Okay. All right, I'm done.
Okay, that is very interesting topic. And to answer, in the first slide, you have projected a question. We love our children. Do they feel love? Okay. In what sense that we will be able to show that we really love them and they can feel it, doctor?
To show and they can feel it. Okay, yeah. What is missing? Yes, go ahead. What do you want to say?
Because in your presentations, you have mentioned about they might have conduct behavior, they might have this kind of cognitive problem or any other mental health issues, but we really love them, doesn't matter whatever conditions or whatever problems that they might be having. So how do we ensure that they really feel our love?
Okay, they really feel our love if we are able to give them the undivided time and attention during the time that we say we want to give them time and attention. Okay, so what does it mean? Well, you know, it's really sad during the pandemic. It's sad because not only the adolescents are coming in depressed. When I ask them, okay, when you sit down for a meal, yeah, what do you guys talk about? You know why I say sad? Because I even had to change my facial expression, because they say things like, we never have meals together. Okay, then I ask them, what about dinner? Do you have dinners together? You don't have dinners together. Okay, then I'm really feeling upset with myself for asking such a question. And then I say, what about weekends? Do you guys spend time together on the weekend? You don't spend time together on the weekend. Right? Or in other scenarios, yes, we do have dinners together, right? Sometimes my parents will force me to come down. I do come down, but we're not talking to one another. Or in another scenario, you know, my parents scold me for being on the phone, but they're on the phone. They themselves are on the phone. And this is two sisters which I've been seeing now. And they say it. Mom scolds me for not coming down on time, so I come down on time. Right? Dad says, okay, I'm home, let's have dinner. Put our phone away, but he's on the phone. So how? Right? Many years ago, in one of the workshops, I said to the participants who were then doctors as well, I said to them, I know you're all busy. Okay? So could you probably spend 15 minutes of your time? If you can't do it every day, maybe once in a couple of days, maybe once a week, for example, whereby in that 15 minutes, the child feels that he or she has your undivided attention. Okay, what does it mean? You put down your phone, it's just you and your child, but you have to do it very early, from very early. You cannot do it when your relationship with your adolescents are already distant. You can't do it because they will pick up and say, what do you want from me, mom? Okay, so do it when the child have this practice about you sit there and what do you talk about? Talking though is different from bangun awal. You kena bangun awal. Kalau tidak, this very different. Talking. So one of the doctors stood up in that workshop, and then he said, "Do you think 15 minutes a day will be enough to have a child who feels secure and safe?" I looked at him and I said, "Can you give your child 15 minutes every day?" You know what his answer was? He said he cannot. So I said, if you cannot give your child that 15 minutes, why are you questioning me? And the reason why I say 15 minutes is I have asked the parents that I see, can you spare half an hour? They can't. Can you spare 15 minutes? Maybe. 15 minutes of being nice. Lain tau. Very different. Give it a try. Yes.
So the answer to that is try to give our undivided attention for
Undivided
15
attention.
minutes from
But
the
how do
very
we talk
beginning
about
of
it?
their life.
Yes.
And
Yes.
do it consequently for until
Yes,
they
ma'am.
are grown up or until forever, perhaps. Yeah.
Yes.
Okay.
Where would you get that 15 minutes?
Usually during going to bed is for me.
Can?
Okay. For you during eating or while waiting for Isha, after Maghrib to Isha.
Yes. Now talking to them. Now talking is communication, yeah. So communication doesn't mean it's one-way street. Means we talk and we sometimes give them to talk, and that's a good practice because then we practice how to answer them. Right? We have to have a mix of the validation, the positive validation. It's tough, for in a lot of family.
Any other question? Or you want to share your experience?
Yes, please share your experience.
Please share with us. If not, maybe I have another question, Dr. Aili. Okay. Usually, when you want to get information from the children and accidentally the information is related to their parents, some kind of bad behavior or some kind of feedback, negative feedback that is related to their parents, then obviously you need to ask these questions to the parents. But how do you ensure that the parents do not lash back to the children? Or how do you assure the children that you won't tell the parents or the parents won't scold them back, so that you will get the information from the children?
Yeah, that's a tricky one.
Yeah.
But usually I just start. So how are things at home? Right?
Okay.
And sometimes apa ni? Sometimes I think the problem is really severe. They will divulge how things are at home.
Oh, okay.
Yeah, right.
They
Or
do.
as what I said, I do a lot of reflection what I see. Right, so they can't run away from it because it's already happening in the room. Right. For example, as what I usually see is that things like you do look tired, or you sound very depressed, or you sound angry. Okay, sometimes it does work actually, because you know why? Because many people grow up in homes whereby there's no validation.
Okay. We have another question, Doctor.
Yes.
I have met a teenager where she has self-harming behavior and we refer to psychiatrists. However, the parents were in denial and said the child has no psychological problems. How do we handle such parents? Yeah, again, the problems is mainly about the parents rather than the children. Yeah, because everything starts at home.
Yes. How do we handle such parents? Okay. I try and handle the children first if the parents are in denial. I don't know whether you see many of these adolescents are they are already feeling really, really fed up and stressful. When by the time they come to us, they really want help. Okay, so what I do is, if I see the parents are not they're not engaging, then I try engage with the child. Okay, so that's okay. The answer to your question is that I try and build, again, which I'm going to talk about next week. I'll try and build the therapeutic alliance very early in the session. Okay, what does it mean? The doctor-patient relationship. For me, it's automatic. I do it immediately that I see the child or the parent. And you're very right. That many times it is the child that we can engage. It's even more difficult to engage the parents. Okay, having said that, a lot of parents are on the understanding that medication has got a lot of side effects. So over the last couple of years, my answer to that is the side effects of not treating a child, or the side effects of not giving the child the opportunity for treatment, is even worse than the side effects of medication, which is true. The side effects of medication, as you all know, last maybe at the first thing that the child feels is the side effects of medication. It can last for 3 to 4 weeks. Yeah, so I go slow. Some psychiatrists, they go very fast because of the severity of the illness, but I go very slow, right? So the side effects goes off eventually. 2, if the child has severe side effects with one group of drugs, we can change it to another group of medication. But the side effects of not treating a depressed and suicidal child is huge, right? So I have to play the waiting game. Okay, so I would say, and sometimes I will go along with the parents and say, yep, whatever it is that you're complaining is because the child is depressed. Yes, the child cannot sleep. Yes, the child is isolating. Yeah, you're very concerned about it. So am I. The child is depressed. So I go on round and round until they're open too. Now, but having said that, you know that in theory, 20% of kids, 20% of your patients will definitely drop out. So we do and save whoever it is that we can, because the work is huge. It's mentally exhausting having to deal with adolescents and their parents.
Okay, all right. You have explained a lot during this session, and you will also have another session next week.
Yeah.
Can you give us some kind of synopsis? What will you be discussing in the next session?
Okay. The next session will not be as easy as today's session. Because I will incorporate what I do in my line of work. I will incorporate the psychodynamic understanding, right? And in my line of work. So I would try and give a little bit of theory, and then I will try and put in a case scenario or 2 case scenarios, and then I will try to not act it out. I would try to, I guess I would try and show you what I do. If when I'm handling such cases, meaning that what are the questions that I will ask, maybe how I will ask it, so on and so forth. Because it's about talking therapy, kan?
Yeah.
So I would hopefully I would try and reenact what I do in my line of work.
Okay, that will be very interesting. I hope every one of you will not miss that session, and please engage. Please ajak more people to join for the next session as well. Yeah, thank you very much, Dr. Aili. We have
No, the
learned
smaller
so
group
much.
better discussion.
Yeah, it's good. It will be a group discussion, yeah, and
Yes.
also some kind of practical session for those who come in the next session. Okay, and if you don't mind, Dr. Aili, can you please post your slide in the chat box later, so that it will be
In the chat box. Yeah.
You will attach your slides in the chat box, so the attendees will have.
I will try. Okay, kejap. Just I will try and do this. Kejap. Next week punya tu mungkin you all might, those who attend might be a little pening because the slides are a little haphazard sikit. Okay, let's see. Boleh? Yes, try.
Yeah, it's there. So everyone, we thank Dr. Aili for her slides, and also for a very great discussion and eye-opening for us. The keyword that I get today, one of them, there's a lot, but one of them is, it's not only to tackle the children, but we must also tackle the parents as well. Okay, for that, SEHAT Selangor would like to thank Dr. Aili and everyone who joined our session today. Hopefully it will benefit all. Thank you from me, Dr. Faiza, and goodbye.
Thank you so much. Thank you.